In today's topic, I'm going to be focusing on a subject matter that is very closely related to pain management, and that is something that I'm very passionate about, the concept of trauma-informed care. And what that actually stems from is the influence of adverse childhood experiences in pain management. Now, many of you may be thinking that this is not going to be related, but as I'll show you over the next 20 to 30 minutes, why and how this is so deeply related, and more importantly, how we should be thinking about care in the NHS and in many other healthcare systems across the world, and why trauma-informed care should be the real way forward. Now, I work as a full-time NHS pain consultant in the United Kingdom. I see patients day in, day out, both in hospital, those who are admitted to the hospital with medical problems. I've seen them before and after surgery, and I see them as part of my community pain health work. And I can assure you, the influence of adverse childhood experiences plays a big role in how patients present and in how we should be managing them, the treatments we offer, the way we communicate, and the way they will interpret our care and our support. What I'm going to focus on is really not just the adverse childhood experiences, but how they impact our immune and nervous system, and how that has an implication in how we look after patients. For example, would you really want to consider doing a major surgery without knowing what the hemoglobin or the iron level of the patient is? And that is how important ACEs or adverse childhood experiences are, in my opinion. Now, we go on to this part here. Now, these are two people who all of you are familiar with. On the left is Matthew Perry. He is the character who plays Chandler from the series Friends. Many of you would have grown up in the 20s and 30s watching him. I certainly did. It was what tinctured a lot of my evenings, watching all the seasons when I first became aware of it in the early 2000s. Matthew Perry died in 2023, and his death was due to an overdose. But what many people do not know, and some people are aware, is actually his problem started because of an episode of back pain that happened probably in his 20s or 30s. And from then on, apparently, he got hooked on to the prescription medication drugs, and from then went on to other drugs there. And that was his problem. But there is something deeper back down as to why he actually ended up with such a severe episode of back pain. And prior to that itself, he had a problem with alcoholism as well. And it goes further back as to why that might be the case. On the right is another very famous figure that all of us are aware of, Lady Gaga. Now, she had to cancel her tour in Brazil many years ago before the pandemic because of a flare-up of her condition, fibromyalgia. And that is again an extremely chronic, widespread pain condition that she struggled with. She has been very open about it in her Netflix series. And I want to tell you that while these two people seem to have very different problems and had the resources to actually try to address their problem, Lady Gaga had huge amount of resources at her disposal to manage her pain. Matthew Perry also said that he spent many millions trying to fight addiction and fight his back pain and treat it without much help. But I'm going to put to you that actually, if you look and see their backstory, adversity in childhood played a significant component of why their immune and nervous systems responded in that way. Matthew Perry talked about the significant emotional neglect that he had as he was growing up as a single child in a broken home. And Lady Gaga has talked about her abuse and the trauma that she suffered after that during her teenage years. Both of these have similarities and differences which are going to be aware. So what I'm going to kind of talk about for this talk and today in this presentation is really go through this complex framework of, what are adverse childhood experiences? Now, what do I think you should be doing and thinking about if you're a healthcare professional or you're a patient listening to this? But the most important part is so what? What does that mean? And what do I think it should mean for healthcare in the UK, within the NHS, and outside? Well, what is an adverse childhood experience? First of all, it is defined as anything that is a chronic or intense or sometimes persistent traumatic stressful event that occurs to someone below the age of 18. And that can mean anywhere in the first 1,000 days, can be during childhood, the transition to puberty, late teen years, and then at the transition to adulthood. 18 is the cutoff generally in how we think about it. But what's more important to understand is that we now know that when the immune and nervous system is developing in that first 18 years, there are possibilities that if the stress or the intensity of the stress or the persistence of the stress is significant and there is no way to change it, then the immune and nervous system adapts and accordingly changes to do the extreme of protection. That has a role to play because how this immune and nervous system gets impacted has a change. More importantly, we notice that there are three particular periods. The first 1,000 days, the period around puberty, and then the late teens to adult transition. So these are again three big phases where there is a lot more change in the nervous system. So stress at these periods are even more of a challenge and can cause even bigger differences in how the immune and nervous system is shaped. Within pain management, we've often talked about we need more evidence to do the things we have in pain management. And there's been a lot of papers that has been written up. On the slide, you will see some of the papers that come through. I'm going to give a broad brush stroke. So first of all, let's look at the evidence base for medication. We know that actually there's data to suggest that most medications are not, unfortunately, super effective. The kind of acronym I use is 30-30-30, not acronym, there's short form there, which essentially says 30% of the drugs would be effective in 30% of the patients in about 30% of the time. And there are studies to actually say that overall we don't have great efficacy with drugs. Next, we go on to, well, for pain management, we can think about injections or interventions like surgery. And the challenge is that there are some studies, indeed there's an orthopedic surgeon from Australia, Ian Harris, who's written a book where he actually suggests that most surgeries are almost like placebo. And indeed, when you try to do a proper trial where you compare a placebo surgery, a sham surgery versus the real one, the few that have been done up to now in some orthopedic surgeries, there's been no difference after 1 or 2 years between the amount of drugs used or the return to work or the pain relief the patients have had and the outcomes they've had. So surgery may not be a success in everyone. And indeed, we have the data to say that 20% of really well done surgeries as well leave people with nerve pain. The third thing is the other big thing a lot of pain clinics and pain management wants to talk about is psychological therapies like CBT, like acceptance and commitment therapy there. The challenge with this as well is that when you look at meta-analysis, big studies, evidence looking at it, again, at best, CBT will reduce the distress and intensity of pain, but it does not take away the pain in itself. So it tries to reduce the suffering, but not the pain. And that's important to understand. That means that the three big pillars most pain clinics can offer in the UK and abroad in terms of looking at probably injections or surgeries. And certainly when people come to the pain clinic, they think there will be a drug, or maybe they'll think there'll be an injection or a surgery, or maybe they'll think some technique like CBT. But the challenge and the reality is that most of these treatments work only to a certain extent. There's also this thought about, let's educate the patient. And we found that actually education alone, just giving information and pieces of paper, unfortunately doesn't cut it as well. There needs to be the empathy and the way to do it, which might make a difference in some ways and change the neuroscience, but that still needs more research. So really what we are looking at now is what's happening. What do you think is happening and why is it? Well, let me give you an sort of example. The name has been changed, but this is a patient who came to my pain clinic a few years ago before the pandemic. Let's call her Amy, shall we? Now, Amy was in a probably early 50s when she came to see me, and Amy had already had an episode of back pain which had started after at work when she was trying to move or lift an object. She felt something go in her back, and then that pain did not go away even after physiotherapy. So she had seen a surgeon, had an MRI done, which showed a disc bulge at the L3-4 level. So she had a couple of injections in her back for her facet joints and an epidural. That did not give much help. Meanwhile, she's also had other complaints at this time. She has been seen by a gastroenterology because she's having tummy troubles. She was also under neurology because she was having headaches, and they are diagnosed as atypical migraine. She'd also been seen by the urology people as well because she was having bladder problems and pelvic pain issues. So she was under both those specialties. When she was seen by a few of my colleagues, they did a few injections. When that didn't get better, the surgeon said, well, let's do a discectomy. Let's sort of take the disc out. Maybe that'll be the end of her back pain. Unfortunately, no. The surgery left her with more back pain and left-sided leg pain. But as happens more often, she was having pain down the leg with the hip and knee being the worst. So she got referred to the hip surgeon and the knee surgeon. The knee surgeon said, well, let's try maybe doing a washout of the knee. And when that didn't work, said that you probably have got some arthritis. Let's do then a uni knee, a sort of single knee replacement. So she had a couple of surgeries. That scar was painful. There was nerve pain in that area there. So that's a new problem. She'd been offered a keyhole surgery of her hip. She was having problems with her shoulder. And all this time, she was also seeing my colleagues in the pain clinic. We were trying a variety of medications, trying simple medications like paracetamol, anti-inflammatories, maybe codeine. Then we were trying the stronger stuff, the gabapentin or the pregabalin, then the really strong opioids like morphine. And she was on a combination of these, but nothing seemed to be making a difference. And by this time, she was having pain in many areas of the body. She'd put on weight. She was out of work for 4 or 5 years. She was pre-diabetic. She was hypertensive. Her weight was going up and her mood was going down. She was then diagnosed to have rheumatology-wise a fibromyalgia. And when she was sitting in my clinic, at that time, there were 3 piles of notes there. And I was struggling. What do I do? In the pain clinic, we'd normally say, well, maybe we'll teach pain management. But actually, even pain management, she'd been to one program and that hadn't made a difference. She was not able to do the 6 or 8 weeks required, did not attend after the 3rd. Well, if you think about it, and I was really having this change that I was seeing patients like Amy in the pain clinic. I was seeing them sometimes in the hospital when they were admitted for other medical problems. I was seeing them when they were coming for surgery as well. So, and the reality is we were seeing Amy's like this everywhere. And for the healthcare professionals among you listening, this might resonate with you. Do you have sometimes patients who do have these multiple diagnoses and multiple challenges coming through? And that's where we have to think about that usually healthcare, in the way we do it, the biomedical way of doing it, we sort of think about the little bits and parts and 10 specialists involved, but nobody had looked at Amy as a person. We forget that there is the person there with all these conditions. That really isn't sometimes, I'd like to say in defense, not entirely every medical doctor's fault, but it's the way the system is. And the system comes from this Cartesian approach of biomedical way of mind-body dualism. And in that sense, we know that in that situation, pain is often thought of as a wire that takes the sensation from the legs to the back of the body, to the brain, and there you could potentially do a surgery, you could cut it open, you could numb it or block it. We do know that that idea and that philosophy of Cartesian mind-body dualism is not right. It's flawed and it's not fit for purpose in how we understand pain and in the context of how we should be looking after such patients. And this is where I would really recommend this book for really understanding the link. Because nothing in biology makes sense if you don't look at pain from an evolutionary perspective and say, well, what's happening? And I came across this book in 2016, which really made me aware of how the body can keep a score of how the changes that happen to the nervous system as it grows. This book made me aware of this next part, the study, the famous study that was done by Vincent Felitti and the team from CDC, which is called the ACEs study, the Adverse Childhood Experiences Study. It was published in 1996, and from what I hear and what I've read, well, what happened is Vincent Felitti was your GP, a primary care physician in San Diego, and he was trying to get his patients to come for the weight loss management program that he was doing as part of his work in Kaiser Permanente Health System. Patients would come along, attend the 6-week program, lose the weight and go back, and then 6 months later they come back with the weight back on. And he'd be wondering, well, what else can I do? And actually that's where he had one of these brilliant epiphanies. He actually sat down and took a complete history of what's happening, what's their life, did a complete information gathering from the patient. And he came across this startling fact that up to 70 to 80% of his female patients who were struggling to have consistent, sustainable weight loss had been sexually abused before the age of 18. They also had a higher incidence of other medical problems as well, physical and mental health. And that's what got him to team up with this from the CDC. And what they did was this landmark study where they said, let's ask 10 questions and let's call them the original 10 adverse childhood experiences. Let's ask in his entire GP practice, I think it was about 14 to 15,000, I don't know the exact numbers, and he asked this entire GP practice, what did they score on these 10 adverse childhood experiences? What were those 10 experiences there? On this slide you can see there were broad categories, so 3 of them were abuse, so it can be physical, emotional or sexual. 2 of them are neglect, physical or emotional neglect. And 5 of them are family dysfunction. As you can see on the slide there, it can be either a broken home, or it can be seeing your parent being beaten, or it can be mental health issues, it can be a separation, it can be incarceration. You can see that these are the 10 big adverse experiences that they asked in that study. We now know over the last 20 years that there can be other traumatic experiences that could also qualify as adversity. It can be a road traffic accident in adulthood. It can be a bereavement or a shock or a divorce or domestic abuse in adulthood. It can be bullying in your workplace. It can be isolation or neglect or being rejected. That can happen at any age, in your school, in your workplace. But all of these are going to make your nervous and immune system change and adapt. Well, when they asked the 10 original questions, that results were now being replicated in so many countries across the world, both in the US and in the UK. In this slide here, which I'm going to show, is actually data from one of the studies that was done, and this actually shows the data from Wales as of 2017. And you can see here that on an average 50% of the population have one adversity before the age of 18. The number of people with 4 or more, which is what the study called as clinically significant, 4 or more adversities, was almost 14%. And if you included the 17% from those who had 3, then you have almost 1/3 of the population having 3 to adverse experiences and more. It has an impact because the data shows that when you have that kind of clinically significant adversity, it means that for every 100 people, you're going to have so much high risk. Almost 20% will have these 4 adverse childhood experiences or more, but it means that they are going to be 20 times more at risk of having mental health issues such as almost wanting to commit suicide or take your own life. It's not about just the social issues like smoking, 10 times more risk of alcoholism or 16 times more use of drug use. It's also physical health, 2.5 times more risk of heart disease. And indeed, this next slide shows a study that came out in 2014. And this data was again from the Welsh population. And if you look on the left here, All of these are physical health conditions that we would not associate with adverse childhood experiences. But look at each one of those physical health long-term conditions on the left, including things like stroke, liver problems, and then look on the right column. That is the statistical significance. When you have 4 or more adverse childhood experiences, all of those physical health conditions are significantly elevated clinically and statistically. That has a huge impact, because what it says is that if you're going to start with a nervous and immune system that has been disrupted right from young age, it's unpredictable, because it's more likely that there's going to be cognitive impairment. It's more likely that you might have adopting high-risk health behaviors. It's more likely that you're going to have disease and disability setting in earlier. And indeed, there's suggestion that people may actually die 20 years earlier than someone who has had no adverse childhood experiences at all. That is the significance of that. I hope I've convinced you about why it matters to know what are adverse childhood experiences. So what do you think you as a healthcare professional or you as a patient ought to do with this information? To me, first of all, understanding why it happens makes a difference. Well, there are many theories about it, but there are certain very good, well-established findings from basic science and clinical research that shows that when the nervous and immune system have been so impacted, it affects the endocrine system and how the cortisol, your stress hormone, is released, how it's regulated, how much is released, does it stay permanently on, does it go up and down? And all of that has an impact on how the rest of your body develops if your hormone secretion is off kilter. You can change that part there. There's obviously some psychological mechanisms as well that people talk about in terms of attachment, in terms of fear avoidance, in terms of threat detection, because your brain's going to be wired to look out to protect you. It's doing that right from childhood. Then it means that it will carry that on into adulthood. So even things that may not be threatening are going to feel like a threat, and the nervous system and immune system will go back to what you did as a child in terms of protecting you. There is this component of there's only a certain amount of effect you can take, what's called the allostasis, the ability to take on that load. Beyond that, if there is so much stress, it causes what's called allostatic overload. And that overload itself is a maladaptive pattern. It's not what the body's meant to do. Our bodies, mammalian bodies, are supposed to respond to acute stress and then have a time for de-stressing and calming down. When that does not happen, it really messes with the hormone and the immune system for the long term. Lastly, we are now realizing that when you have this kind of stress, it changes what kind of genes are expressed, what's called as epigenetics. So, you have certain genes, you might be predisposed to something, but actually having that much of immune and nervous system impact because of adversity, it changes which genes are expressed, and there are epigenetic mechanisms also kicking into place. And the last new bit of research that's coming through when I talk about the immune system, we have a representative of the immune system in the brain. It's called the microglia, and there are other cells like astrocytes, but the microglia start to almost become, they cause collateral damage when they get activated. Imagine that they are like the Dr. Jekyll. They are looking after you, they are looking after your nerves when you're normal, but when they detect the stress, they have these cameras on them and they detect the stress, they start to become activated, and that way they become like a Mr. Hyde. They cause a lot of local damage, they release chemicals, and microglial activation is also supposed to be a reason for these kind of adverse impacts that happen to the nervous and immune system as you grow older. And when I say older, it means that these kind of changes can start to show by the 20s or 30s itself. It's not 50s or 60s, it's much earlier in life. That all, as you can see, is very relevant in pain management. What I've described up now as adversity in childhood, but you see that all the mechanisms I talked about microglial activation, about the changes that happen in the epigenetics, about the changes of threat detection and fear avoidance, they are all things we talk about in pain management. We are aware in pain management as well. Because what happens in pain management? Well, if you think about it, we talk about the fact that the new way to understand pain is not to think that all the information only comes from the periphery. Indeed, the brain is an active part. It takes part in predicting, based on the context, what the response should be. So if you have, for example, an injury that happens at the periphery in those black areas that's there, it travels down the nerve, it comes to the middle of the spinal cord, and the information is then sent up towards the brain. The brain then has to rapidly compare to its previous memories. It has to look at the context, and it has to decide, is this prediction right? Do I need to change my prediction? What's the error? Because ultimately what it wants to do, it has to protect you. And so it has to do a lot of this prediction and processing in order to protect you. And if it decides to protect you, it's going to indicate that a pain experience has to come on. So you might say, well, what is it trying to protect you from? It can be threats of the past. It can be external threats. Those are the injuries, the surgery, the infection. It can be the internal threats, things that come from within us. Most commonly, that's where I think nutrition and the gut and the microbiome, which I talk about, makes a difference. But the threats of the distant past, the memories, the thoughts, the fears, the faces, all of that can reactivate the same system again. This is how adversity can shape the immune and nervous system as far as pain management is concerned. Indeed, there is a lot of evidence now, and I've written a part of a paper from the University of Reading, where we've talked about the fact that when adversity is there, there's 3 times almost more chance of chronic pain than someone who did not have that adversity there. And people who do have significant adversity will have multiple pain issues, multiple areas which are painful. In our normal setup, they might end up going to multiple doctors, seeking multiple labels and having multiple diagnoses and more procedures and lots of drugs. You remember I told you about Amy earlier in the talk? Well, when I spoke to Amy and asked her those 10 questions of the Adverse Childhood Experience Questionnaire, she ticked 9 out of 10. So you can imagine how much traumatized that nervous and immune system of hers was, and it could explain to me why she had so many complaints and symptoms that were going on. All of this has a reason to play. You might say, well, is that relevant in a pain clinic? I actually had that same doubt myself. So I conducted this experiment, a survey in my hospital, in my pain clinic within the NHS, which is a secondary care pain clinic, in 2018. For about a 10-week period, every new patient that came to the pain clinic got given the ACE questionnaire. They were told why we were asking it. Nobody complained. One or two probably were more curious and were reserved, but everybody else were happy to fill out that questions and answer it. They could see that it made sense. Many of them were curious and actually saying, I can understand now, and that made sense to them. So actually it's not as worrying as we think it would be, but in that it was revealed so much more. I could see that there were patients, one, who were happy to fill out that information and were okay to give that out. But more importantly, they were also identifying so many other medical health conditions that are seen on the slide here that they said, yes, they were suffering from. But in terms of the 10 questions there, I asked, the first question was, did you have a happy childhood? And actually out of that 10-week period, we had about 134 questionnaires, 47. So almost 40% of the people said they had an unhappy childhood. And out of that 47 people, 75% had 4 or more adverse childhood experiences. That means in the United Kingdom, in a secondary care setup, more than 1/3 of the patients that come to our service have got very significantly vulnerable and traumatized immune and nervous systems. That has an impact. We need to do this on more wider scale in a hospital setting as well, but that means we need to see how we can serve our patients in the pain clinic better. We often talk about resilience. Resilience, we understand, is not so much about a person being resilient, but actually it's about the support that's provided to the patient around themselves. What social factors do they have? What familial support do they have? What work-based support do they have? All of that becomes important when we measure somebody's resilience overall. Because my view, and it's my opinion and reading of the literature and the data, is that if we've got someone who's got high degree of adversity, meaning that their nervous and immune systems are already vulnerable and traumatized, and they have low resilience, meaning that their social support factors are all affected or impacted and not available, that sets the stage for how their nervous system might be affected, and that can cascade down into what we call central sensitivity syndromes. It can affect their immune system, and that can cascade into autoimmune disorders or even cancer. It can affect their hormone system, and that can be the onset of metabolic syndromes, diabetes, hypertension, obesity. Or it can affect their developing brain structures that mediate mood and emotion, and that can be the mental health disorders that we have read about and known about. It's not comprehensive, and it doesn't mean that everything can be explained due to adversity, but I've seen this, and the research backs up as well that all of these are more elevated when you have adversity in childhood. What does that mean? It means that we need to really look carefully at adverse childhood experiences and its influence on pain management, and actually think about what can we do for practical clinical purposes when we look after patients with pain. And actually we need to be talking more about this and considering screening on a larger scale as routine if possible. That's what we try to get across, and at least bring around that concept of trauma-informed. All clinicians, all healthcare professionals, and I'd argue most members of the public should be aware that when trauma happens, it can impact the immune and nervous system, and each person is different. And that's why I think we all, especially healthcare professionals listening to this, we realize that we are contributing usually to only 20% of the hospital side of a person's well-being and health. The remaining 80% is dictated by their physical environment, by their social environment, by their economic structure, by the health behaviors they adopt. That means we need to think more often about how we all can go upstream and prevent our patients from falling down the waterfall, and maybe even go even further upstream and actually ask, can we prevent them from being thrown into the water in the first place? I hope you agree with me, and you can see that logic of why we need to be doing. And that's what's called the trauma-informed upstream approach. It's what I practice out there, but mainly, now that I've told you this, the so what? Now what would I like you to do? As a patient, as a healthcare professional, what are the practical applications? I think there are a few. First of all, in realizing that trauma itself is a combination of three things. That the trauma was unexpected, the person was not prepared for it, and they didn't have any agency to change it. Think about how we felt during COVID. Think about anybody, a child who undergoes that adversity, or somebody adult who is in a domestic abuse, in a violent relationship. They feel that they do not know the initial bit of unexpectedness, that they have no agency to control it. All of this is important because we need to then think about the 4 R's of trauma-informed practice. We need to actually recognize that it is very prevalent. Realizing it is the first, recognizing that it is happening, and then we need to respond to it, because ultimately our response as a healthcare system, as a family unit, will make sure that the way we communicate, the way we talk about things will prevent re-traumatization. We want to resist re-traumatizing that already vulnerable immune and nervous system. Now we can do it as a one-to-one in each of our interactions when we talk with patients, when we talk with our family members. And there is a case to be said in the US. There are many organizations and health systems that have said we can do this at a larger scale across the organization. Ultimately, as Gabor Mate has famously said, trauma is not what happens to you, trauma is what happens inside of you when trauma happens to you. And if you think about it, is trauma-informed care the answer? I actually would say that trauma-informed care should be the way we do it, because in a healthcare system, and this specifically applies to a lot of healthcare professionals listening to this talk, we are being asked to provide personalized care. This is the day of AI and ChatGPT and Bard and Gemini, and all of these are wanting to provide personalized, curated recommendations. So when we want our medicine to be personalized and participatory and progressive, when we want to think in an integrated fashion and we want to keep it sustainable, when we want to think about the patient as a whole, think about Amy as a whole, we need to think about the social determinants of health. We need to think about how we support people with long-term conditions and pain with behavior change. I think trauma-informed care is the best way forward, because that means you're going to come at it from a place of empathy and compassion. And that's what being trauma-informed and adverse childhood experience aware is to be compassionate, to be asking the question, what happened to your immune and nervous system, rather than saying, why are they like this? That's the point. What happened to this person? What are they trying to protect? What are their nervous systems trying to do? And I would suggest to all of you healthcare professionals and to even patients, when you have that kind of adversity as a background vulnerability and you have low resilience factors, we need to be careful about strong drugs or potentially addictive drugs like gabapentinoids or opioids in pain management, because if we don't get the timing right, that's where their nervous systems can get hooked onto that, can feel that kind of distress reduction that comes with these drugs, becomes a force that the dopamine hit takes over, and that's what we call as addiction. That can happen. When it comes to talking about interventions, we need to make sure that we don't use the negative frame. If you frighten somebody into giving up opioids or the bad of a surgery or any intervention, you're going to be making their nervous systems more traumatized. So how can you change or shape your communication so that it is more compassionate, more trauma-informed, more aware that what you say, how you say makes a difference? This goes out to all you surgeons who might say, oh, your spine is crumbling or your spine is like a digestive biscuit. That is all really traumatizing, unfair, and actually not true. You can imagine how that would make the patient think. So think about the communication and the language. And actually that's where we need to then think about injections as well. When are they going to work? How do you frame the interventions we want to do? And what else can you do to think about calming the nervous system? Because with CBT or psychological therapies, you are assuming that the person's nervous system is rational and that their frontal lobes, their front part of the brain, which is their executive function, can actually make a decision and override their emotional center. That's not true. When you're afraid, when you're traumatized, when you're vulnerable, your nervous system is going to be running off your amygdala, your emotional center, your frontal lobe or your executive function is reduced. That means you cannot really use sometimes these CBT style techniques because they may not be effective. And that's something to be aware. And I would say that that may be a reason why sometimes our patients don't respond to those techniques that we do, because ultimately you want to provide that patient safety, and when you have safety and you give them choice and you collaborate with them, that's where all this comes, and trust is earned. You can get change, you can empower them, you can make healthcare more sustainable, hopefully. I hope I've been able to convince you on this, and there are certainly within the NHS that is possible. For example, in my organization, we have this tick box called the Veterans Aware, which essentially is trauma-informed care for the veterans population. My view is, if we have systems in place in organizations in the United Kingdom which are already doing trauma-informed care for one cohort of people, what's required to actually scale it up and offer it in primary care, in secondary care, in community care? And I think it's possible to do. One simple method which doesn't take long, it's just about utilizing these simple principles of safety, choice, and collaboration leading to empowerment, is this method called the CARE method. Links will be provided in the video at the end, and I will also link to the YouTube video by two US psychiatrists who promoted this method. It's called the CARE approach, and it's simple. The C stands for just taking consent. The A is to be asking about it. R is reflection. And E is then engaging. The reality is you're going to be first taking consent. And if they don't want to give consent, that's it. You don't lose any time. You haven't done anything at all. But if give a consent, you can just ask them about what that adversity means or whether they have had that. The fact that they're able to talk about it and open to you is part of rapport, is part of collaboration, it's part of the trust. And then you can reflect with them and get them to engage on it if it's necessary. The data shows that asking about it means you're not going to open up Pandora's box, you're not going to make it difficult for your patients. And actually, the suggestion is that most patients may just feel a little light having made the link or talked about it, but they don't necessarily need to process it or work through it. It doesn't have to apply for everyone. So I don't think it's going to increase the workload. In my practice, in my organization, we've had this for about 3 years now. I'm doing this video in 2023, and we've had this from 2020 onwards. We've had very few patients who've been had to refer further, and we see on an average 1,000 to 2,000 new patients a year. So we know that it does not really increase specifically the workload due to ACEs in it particular. So I hope I can reassure you that actually screening is worth it. Screening is easy to do. And for patients, those of you who are listening to it, consider this option to see if that might open a link and a way to discuss with your healthcare professional. Because ultimately, when you want to think about pain management, a lot of us who do pain clinics, who work in pain clinics, and when patients yourself, if you go to pain clinics, you want to know what drugs to use, you want to know what medications to use, and then that's what a lot of pain clinics do. We do the what very well. We also do the how quite well. We've got pain management programs, we've got group consultations. All of this can help in changing and helping people. But I think understanding the why, the trauma-informed care, the role of adversity, that why is important. And as Simon Sinek says, start with why. You want to know the why, then the what and the how becomes explanatory, easy, and logical to do. And that's where I think the influence of adverse childhood experiences on pain management and future pain practice are. It's essentially, I think it's a part of what is this new concept of value-based healthcare. It's about taking this concept of working in the community, because not all of it can be done or needs to be done in a specialist setting. It can be done in a community. You can work with the patient's community where they live, the councils, the social prescribing areas. So it gives a reason for us to integrate and work across the system with our colleagues to support our patients. That means how you do your pre-operative patients coming for surgery with these kind of ACEs. How do you support them? You've already got a system in place. And that, I think, is the future of hospital practice. How you use perioperatively before surgery and after surgery can be changed. And that means you might make a difference in a lot of the chronic pain, because they're often a mixture of big trauma and small trauma in most patients with chronic pain. So I think there is value in doing this, because potentially these are like the patients who have a hemoglobin of 4 or 5. For those of you who are listening to this and not medical, we gently tend to think that a hemoglobin of 7 to 8 at the minimum is required if you want to undergo a major surgery. But these patients who have got significant adversity are like those patients who have got a low hemoglobin. We need to know what it is. We may not necessarily need to give blood in everyone, but we might want to think of how to optimize some by nutrition, maybe have more spinach. You might want to optimize some people by giving them iron tablets. You might want to change somebody's by giving them an infusion, but you want to do something to them because you become aware of that information. And that's what I think screening for adversity is. At least makes you aware that you can do some optimization. You don't have to deny them something. Because that's what I think is the art of really good pain management. The art lies in knowing when to lead the way, when to walk alongside, and when to follow. And in sensing it is going to be the most important part. I hope you've really gained value from this, and the influence of adverse childhood experiences. It's a topic close to my heart. I'm going to leave some resources as well that you can look at. And my book, The Pain-Free Mindset, to me actually just captures that understanding of the trauma-informed care and provides a little bit of the why, a lot of the what, and the how of that. So thank you for listening to this, and I'll see you in the next video.